Welcome back to the Deep Dive. Today we are shifting gears a little bit. Usually we take a really broad look at a topic, maybe something in tech or history, but today we are launching a brand new format we're calling Prism Rounds.
That's right.
We're going straight into the intensive care unit, right to the bedside, to look at the decisions that, really determine life and death at 3 or 4 a.m.
Yeah, this is for the clinician, or really just for the deeply curious learner who wants to go beyond the abstract of a paper. We aren't just asking what happened in the study. That's just the start.
Right.
We are asking, how does this change the way I think, the way I act, and maybe most importantly, the way I treat the human being in that bed?
And to kick this off, I want to talk about a ritual, a specific, almost religious ritual in critical care.
Oh, I have a feeling I know exactly where you're going with this.
The arterial line, the A line.
The red wave.
Yeah.
The security blanket of the intensivist. It really is.
It's a perfect term for it, security blanket. I mean, picture the scene, right? A patient rolls into the ICU. They're hypotensive. They're septic. Maybe they're a little clammy, a bit altered. What is the very first thing that happens after the IVs are in?
You grab the ultrasound, you grab the aero kit, you prep the wrist, you put in the line. It's automatic. I mean, it's practically a reflex arc in our brains. Shock equals A line, period.
Exactly. And let's talk about why that feels so good. There is something so visceral about plugging that transducer in and seeing that bright red waveform just appear on the monitor. You see the systolic, the diastolic, the little dichrotic notch. It gives you this sense of immediate high-fidelity control.
It's the illusion of mastery, isn't it? In a totally chaotic situation where a patient is frankly trying to die on you, that waveform is a constant. It's this one piece of data that tells you beat by beat exactly what the vascular system is doing.
Beat by beat.
If you start a vasopressor, you literally see the pressure rise in 10 seconds. If you give a fluid bolus, you see the stroke volume variation change. It feels like you're flying a fighter jet versus, flying a glider with a map.
That is a perfect analogy. But here's the provocation for today's deep dive, and it is an uncomfortable one. Is that feeling of control, that fighter jet feeling, actually helping the patient? Or is it just treating the doctor's anxiety?
And that is the question that, should keep us up at night. Are we doing these invasive procedures because they truly improve survival? Or are we doing them because they make us feel like we are doing real medicine?
Well, today we are going to find out. We are dissecting the EVERDAC trial.
EVERDAC. Early versus deferred arterial catheterization. This was just published recently in the New England Journal of Medicine by Muller and colleagues, and it attacks that shock equals A-line dogma head-on.
The core premise sounds almost heretical to an old-school intensivist. They basically asked a very simple but profound question. Can we safely manage a patient in true shock using just a standard blood pressure cuff?
Just a cuff. The same cuff you get at your GP's office. The same cuff that, wheezes and pops and takes 45 seconds to give you a single number. Can that replace the fighter jet controls?
Before we dive into the data, I want to linger on that pre-trial dogma a little bit more. Because for listeners who aren't in the ICU every day, they might be thinking, well, of course you'd want the best data possible. Why wouldn't you?
And it's a totally valid question. The argument for the A-line has always been about two things: precision and speed.
Okay.
In shock, blood pressure can fluctuate wildly, moment to moment. If a patient crashes and you are relying on a cuff that cycles, say, every 5 minutes, you might miss 4 minutes and 59 seconds of profound hypotension.
That's a huge tap.
It is. That is 5 minutes where the kidneys aren't getting blood flow, where the brain is suffering, where the gut is becoming ischemic.
Right. It's the gap of uncertainty. It feels like you're driving down a highway at 100 miles an hour and you just decide to close your eyes for 5 seconds. That's what relying on the cuff feels like.
Whereas the A-line is eyes wide open, staring at the road every single second. Plus, there's the accuracy argument.
This is the other big one.
Yeah, we have always been taught that when a patient is clamped down, vasoconstricted from high-dose pressors, the cuff becomes unreliable, the sound it's listening for gets muffled.
So it might read a mean arterial pressure, a MAP of 65, when the real true central pressure is actually 50. Or I guess vice versa.
Exactly. It could go either way. So the dogma is built on these two pillars. 1, the cuff is too slow, and 2, the cuff is inaccurate in really sick people. Therefore, the A-line is mandatory for shock.
Correct. That has been the standard of care for decades.
For my entire career.
So enter EVERDAC. Why now? Why are we questioning this foundational belief right now?
The context here is everything. We are in an era of critical care where we are, and should be, questioning everything that adds complexity without a clear benefit. We've been through this before.
Like with tight glycemic control.
Exactly, the nice sugar trial. We thought tighter glucose control had to be better. Turns out it caused more hypoglycemia and potentially more deaths. We saw it with early goal-directed therapy in sepsis. We're realizing that our aggressive interventions often bring aggressive and sometimes hidden side effects.
And this ties directly into the editorial that accompanied the paper, which was written by Dr. Haley Gershengorn. She frames this beautifully.
She does. She talks about this whole philosophy of less is more. For a long, long time, the ICU was a place where we just added things. More tubes, more lines, more drugs, more sedation. The thinking was, if you weren't actively doing something to the patient, were you even treating them?
It's the action bias. We feel better if we do something the patient still has a bad outcome than if we do nothing and they have a bad outcome.
Precisely. But Dr. Gershengorn argues that modern intensive care is, or should be, pivoting toward humanization. We want patients awake. We want them moving. We want them liberated from tethers. And the A-line is a tether. It's a literal plastic anchor that keeps you in bed.
So the mission of EVERDAC wasn't just, can we save money on plastic tubes? It was something much bigger. It was, can we strip away some of the machinery and still save the life?
Exactly. The mission was to prove non-inferiority, to prove that this less invasive strategy isn't significantly worse when it comes to living or dying.
Okay, let's get into the nitty-gritty. The setup. Let's talk PLI-KEO. Who were these patients?
This is crucial because, trials live and die by their inclusion criteria. They looked at adult patients admitted to the ICU with a diagnosis of acute circulatory failure.
Acute circulatory failure. That's just a fancy, researchy way of saying shock, right?
It is, but they defined it very specifically. These patients had to be on vasopressors, like norepinephrine, or have clear signs of severe hypoperfusion, like a high lactate. And this is the key. They were randomized early, within 24 hours of ICU admission.
And why is that 24-hour window so important?
Because that's the so-called golden hour period. That's when the patient is sickest, most unstable, and when that decision to place a line is almost always made. If you wait 48 hours to randomize, you've missed the window where the A-line theoretically helps the most. You'd be studying a different population.
So they grab them right at the door, essentially.
Right.
You're in shock. You're in the study. Randomized.
Exactly. A very pragmatic approach.
So now let's look at the two corners of the ring. In the blue corner, we have the standard group, the intervention.
Right. The invasive strategy. These patients got an arterial line placed immediately. The protocol said within 4 hours of randomization. This mimics current standard practice. Stick the wrist, wire in, transducer up, waveform on the screen.
And in the red corner, the challenger, the cuff-only group.
This was the deferred strategy or the comparator. They used automated oscillometry, the standard cuff that we've been talking about. But, and I really cannot stress this enough, this was not a ban on A-lines.
That's a really important distinction. It wasn't, you can never have an A-line no matter what happens.
No, of course not. That would be completely unethical. If a patient is dying because you can't get a reliable blood pressure reading, you can't just shrug your shoulders and say, sorry, the protocol says we have to use the cuff.
So they built in what they called rescue criteria.
Yes. Or safety triggers, you would call them. The protocol was clear. Start with the cuff. But if specific things happen, if the patient gets too sick or the cuff itself just fails, then you pull the ripcord and you place the line. No questions asked.
So before we get to the results, I have a question for you and for the listener. Before we even look at the data, what would make you personally distrust a cuff in a shock patient? What are the red flags for you?
For me, it's a few things. Severe obesity is a big one. A BMI of 45 or 50. The arm is more of a cone than a cylinder, and the cuff just can't get a good wrap.
Right, the physics are against you.
The physics are against you. Severe peripheral edema is another. A very irregular heart rhythm, like rapid atrial fibrillation, can confuse the cuff's algorithm. And then there's the really profound low flow state where you can barely even feel a pulse. In those cases, my faith in the cuff definitely starts to wane.
That makes sense. It's not a magical device. And the study acknowledged that by having those rescue criteria. Okay, so we have our population, our intervention, our comparator. What about the outcome?
The primary outcome was as simple and important as it gets. Death from any cause at day 28. Just a binary dead or alive.
But they also looked at harms. And I want to flag this for later because I think the balance between survival and suffering is maybe the real story here.
I completely agree. They track the obvious line complications, things like hematoma, hemorrhage, ischemia, infection, but they also track the pincushion effect. How many times did the patient actually get stuck with a needle for a blood draw?
That's a great patient-centered outcome.
Yeah.
Okay, let's get into the methods. How did they actually run this thing?
It was a pragmatic, multi-center, non-inferiority, randomized controlled trial, and it was open label.
Open label, meaning you can't blind it. You can't really hide a plastic tube sticking out of someone's wrist.
Exactly. The doctor and the nurse knew which group the patient was in. And that's important when we talk about bias later.
So let's do a teach the fellow moment here.
Yeah.
We hear this term all the time in Journal Club, non-inferiority.
It sounds a little mediocre. It sounds like you're trying to prove your new treatment is just as bad as the old one.
It gets a bad rap. It really does.
Sure.
But in medicine, it is an incredibly powerful and valuable tool. Think of it this way. Suppose you have a new cancer drug. The old drug works, but it's incredibly expensive, it causes terrible nausea, and it makes all your hair fall out.
Okay.
Now, you invent a new drug. It's cheap, it tastes like strawberries, and it has 0 side effects. You don't need the strawberry drug to work better than the old drug. You just need it to work the same at killing the cancer. Right. If it saves the same number of lives, you'd switch to it in a heartbeat because of all the other benefits, the taste, the cost, the side effects.
Exactly. So you are not testing for superiority. You are testing to see if the new treatment is not unacceptably worse.
Not unacceptably worse. That's the key phrase. And to define what's unacceptable, you have to set a margin, a boundary, a line in the sand.
You do. And in EVERDAC, the non-inferiority margin was set at 5 percentage points for the risk difference in mortality.
Okay, let's unpack that number, 5%. That means if the CUP group had a mortality rate that was, say, 4.9% higher than the A-line group, the study would still declare the CUF a success, or non-inferior.
That's correct. As long as the upper limit of the confidence interval for the difference didn't cross that plus 5% line, the primary endpoint was met.
That seems high. I mean, if I told the patient, hey, this new approach might increase your risk of dying by nearly 5%, but don't worry, it's considered non-inferior, they might, run out of the hospital.
It is a controversial margin, and you're right to question it. The editorial by Dr. Gershengorn actually points this out. She notes that 5% is a fairly large difference when your outcome is death. In a study with the baseline mortality around 35%, a 5% absolute difference is a pretty big relative change.
Right. In a study of 2,000 patients, a 5% difference is 100 people.
It is. It's a lot of lives. But you have to balance that against the reality of clinical trials. To prove non-inferiority with, say, a 1% margin, you would need a sample size of tens and tens of thousands of patients. It would be impossible to fund or run. So 5% is a pretty standard, if uncomfortable, pragmatic compromise in critical care trials.
So it's a trade-off between statistical purity and practical feasibility.
It always is. So with that 5% goalpost set, the question is, did the cuff stay between the posts?
Let's find out. Let's hit the results. What are the headline numbers?
Okay, the primary outcome, 28-day mortality. Drum roll, please.
I'm on the edge of my seat.
In the invasive A-line group, the mortality was 36.9%.
Okay, so about 1 in 3 patients died, which is pretty typical for a shock population in a trial.
Exactly. Now, in the cuff-only group, the mortality was 34.3%.
Wait, pause for a second. The cuff group actually had lower mortality.
Numerically, yes, about 2.6% lower in absolute terms.
So fewer people died in the group that didn't get the fancy invasive fighter jet monitor.
That is what the raw numbers say. Now, statistically, we have to be very careful here. Because of the confidence intervals in the study design, we call this no difference or non-inferior. We absolutely cannot claim that the cuff saves lives based on this. That would be a huge misinterpretation.
Right. It wasn't powered to prove superiority.
But we can certainly say, with a high degree of confidence, that it didn't kill people. In fact, the point estimate went in the other direction.
And the confidence interval is the key to that confidence.
It is. The final adjusted risk difference was 3.2%, and the 95% confidence interval ranged from 8.9% to plus 2.5%.
Okay, translate that confidence interval for us. What does that range mean in plain English?
It means that while our best guess is that the cuff strategy reduces mortality by about 3.2%, the true effect could be as good as an 8.9% reduction or as bad as a 2.5% increase in mortality.
But that worst-case scenario for the upper end of that interval at plus 2.5% is well below the 5% margin we talked about.
Well below, not even close. So we can be very, very confident that the cuff strategy is safe regarding survival. The trial met its primary endpoint.
That is a mic drop moment for decades of dogma. The foundational idea that you need an A-line to manage shock safely is just, well, it seems to be wrong.
It appears to be a belief, not a fact. But now we have to talk about the price of that safety, because this is where that strawberry drug analogy comes back into play. If survival is the same, why should we switch? What is the strawberry flavor of using the cuff?
It's the lack of complications.
Bingo. Let's talk about harms. In the invasive group, the rate of a major hematoma or hemorrhage at the insertion site was 8.2%.
Almost 1 in 10 patients. And let's be real for a second. What does an A-line hematoma actually look like? This isn't just a little bruise.
No, not at all. It's a wrist that swells up like a grapefruit. It's dark purple blood tracking all the way up the forearm. It is really painful. It can compress nerves and cause numbness or tingling in the hand. In rare, awful cases, it can lead to hand ischemia. And it basically ruins that radial artery for any future use.
So a really meaningful, painful complication. And in the cuff group, what was the rate there?
1.0%.
So an 8-fold reduction in bleeding complications.
Yes, that's an absolute risk reduction of 7.2%. It means
Right.
for every 14 patients you manage with a cuff-first strategy, you prevent one of these significant bleeding complications. That is a huge number.
So if mortality and even things like organ failure days are basically the same, does this complication delta become the real headline of the study?
I think it has to be. You have two strategies that get the patient to the same survival outcome, but one of them causes a painful, disabling complication in 8% of patients, and the other one doesn't. The choice seems pretty clear.
But, and there is always a but, there is a trade-off. Because you don't have that convenient line, you still need to get blood samples.
The pincushion effect, this is the part of the study that, really hit home for me as a clinician. In the cuff group, patients had 2.76 times more arterial punctures for blood sampling.
So instead of placing the line once and then just painlessly drawing labs off a port for 3 or 4 days,
You're sending the nurse or the respiratory therapist in there with a needle to stick their radial artery 3, 4, maybe 5 times a day to check blood gases.
and that is brutal. An arterial stick hurts way more than a standard venous stick. It's deep, it throbs. It's unpleasant for everyone involved.
It is. And the study captured this. They actually asked patients about pain and discomfort, and it was significantly higher in the cuff group. 13.1% reported significant discomfort versus only 9.0% in the A-line group.
And it's not just the needles, though, is it? It's the cuff itself.
Oh, the cuff squeeze. Have you ever tried to sleep in a hospital with a blood pressure cuff cycling every 15 minutes?
I have. It is absolutely impossible. Just as you start to drift off, squeeze, your entire arm goes numb, your fingers start to tingle, and then it wakes you right back up.
It's a form of torture. It probably creates delirium. It creates agitation. So we are trading one type of very visible harm, the hematoma, for another type of harm, which is pain, anxiety, and sleep fragmentation.
That is a tough calculus. I mean, how do you present that? Mrs. Jones, we have 2 options. We can put this plastic tube in your wrist, which has about an 8% chance of causing a big painful bleed, or we can just squeeze your arm all night and stick you with needles 4 times a day.
It's a classic pick your poison. But, and here's the nuance we can't forget, the A-line prevents mobility. The cuff allows movement, so you're also trading tethered to the bed versus free to get up and move to a chair. And we know how important early mobility is.
That's a great point. Which brings us back to those rescue criteria. Because I can hear the critics shouting right now, the cuff group only did well because a bunch of them eventually got lines anyway.
That's the key question. Let's look at the crossover data. How many people in the cuff group actually needed to pull the parachute and get an A-line?
Just guessing. Based on how sick these patients were, I would guess maybe 50%.
I would have guessed that too. The actual number was about 15%.
Only 15%. So you're telling me that 85% of patients in true circulatory shock people, sick enough to be in an ICU on vasopressors, were managed from start to finish and never needed an A-line.
Correct. That number stunned me. I would have bet a lot of money it would have been higher. It shows just how resilient our physiology is and honestly, how much more accurate modern cuffs actually are than we give them credit for.
Okay, so for that 15% who did crossover, what triggered the line, this is the fine print section, and it's probably the most important part for our listeners who want to actually apply this tomorrow.
The triggers were all very sensible and clinically grounded.
Unreliable cuff. If the cuff just kept erroring out or giving numbers that were wildly different from the patient's clinical signs.
Makes sense. If the tool is broken, get a new tool.
Exactly. Number 2, safety. If you couldn't get a reliable pulse oximetry or SpO2 signal that suggests peripheral perfusion is just too poor.
Procedure failure. This one's important. If the team tried to stick them for an ABG 5 or more times and failed,
Which is just humane. Please, for the love of God, stop sticking them after the 5th time and just put the line in.
please, exactly. Number 4, major change in clinical status. This was for things like going on ECMO or needing high-risk emergency surgery where you need beat-to-beat monitoring. And then number 5, the big one.
A massive dose trigger.
The protocol allowed clinicians to place a line if the patient was on a very high dose of vasopressors. But we need to stop everything and do some math here, because dose is not a universal language.
This is the tartrate versus base trap. I feel like this is a secret handshake in pharmacy and European ICU circles that most North American doctors just ignore.
We ignore it at our peril. Okay, let's role play this for a second. I have a patient, Mr. Smith. He's a standard 80-kilogram guy. The EVERDAC trial, which was run in France, says the safety trigger to place a line is when the dose of norepinephrine, plus any epinephrine, exceeds 2.5 micrograms per kilogram per minute.
Okay, 2.5 Mexman, that sounds insane. In my unit, if someone is on 0.5 Mexman, everyone is panicking. 2.5 implies they're basically dead.
It does. It sounds astronomically high, but you have to look at the fine print in the method section, the label on the vial in the study. It says norepinephrine tartrate.
Ah, tartrate. That's the salt form it's mixed with.
Right. Norepinephrine is an amine. To make it stable in a liquid solution for an IV bag, it's bound to tartaric acid. The tartrate molecule is heavy. It's like a heavy backpack attached to the active drug. The ratio of molecular weight is roughly 2:1. So 2 micrograms of norepinephrine tartrate contains roughly 1 microgram of norepinephrine base.
So the tartrate dose includes the weight of that backpack. The base dose, which is what we usually use, is just the active drug itself.
Exactly. Now, in the U.S., at OHSU, at most academic centers using EPIC or SLUMR, how do we chart our norepinephrine?
We chart in base, almost exclusively. The order sets are built for base.
So we have to convert the trial's trigger to our language to understand what it really means for our practice. The trial trigger was 2.5 micrograms of tartrate. You divide that by 2. That equals 1.25 micrograms per kilogram per minute of base.
Okay, 1.25 Mexman of base. Let's go back to Mr. Smith, our 80-kilogram guy. 1.25 times 80 is 100 micrograms per minute total. That is 2, maybe 3 maxed out bags of Levofed running wide open into the patient.
It is a massive, massive dose. This isn't just shock. This is biblical shock. This is refractory vasodilatory collapse.
So the study didn't say place an A-line when they start on pressors. It said it is safe to use a cuff until they're on a dose so high that they're likely to die within the next hour anyway.
Precisely. And this is where the cognitive dissonance hits for me as a practicing clinician. At my hospital, we often place lines when a patient gets to 0.05 or 0.1 mg of base. The study says you are probably safe with a cuff all the way up to 1.25. That is a 10x to 12x difference in the threshold for invasion.
That is mind-blowing. We are pulling the trigger when the car is going 10 miles an hour, and the study says the car doesn't really crash until it hits 120 miles an hour.
It completely reframes the safety argument. It suggests we aren't placing lines because the patient needs them from a physiological standpoint. We are placing them because we are uncomfortable without them. But the data says the patient is actually fine.
I just want to really hammer this home for the listeners. If you're reading this paper, or any European ICU paper, you must check the methods to see if they are reporting tartrate or base. Because if you try to run your unit based on tartrate numbers, but your pumps are programmed for base, you're going to massively mismanage your thresholds and potentially harm patients.
Always check the methods section. Norepinephrine expressed as tartrate salt versus expressed as base. It's one single line of text that changes the entire interpretation of the trial.
Okay, that was a crucial detour. Let's move to the critical appraisal. No study is perfect. Where are the holes or the boundaries of EVERDAC?
The biggest boundary, I think, is the exclusions. They excluded patients with a BMI 40.
Which in North America is a huge chunk of our ICU population.
It is, and it was for a good reason. As we discussed, we know cuffs can fail in severe obesity. The arm is cone-shaped, the bladder doesn't encircle the arm properly, the pressure transmission is dampened by all the soft tissue.
So the big takeaway here is, if you have a patient with a BMI of 50 and septic shock, do not use this trial to justify cuff only. Put the line in.
Agreed. The physics just don't work for the cuff in that situation. They also excluded patients with severe traumatic brain injury, TBI.
And why was that?
Because in TBI, the brain is swelling. The intracranial pressure, or ICP, is rising. Your job as an intensivist is to keep the mean arterial pressure, MAP, high enough to push blood into the brain against that swelling pressure. This is called the cerebral perfusion pressure, or CPP. A drop in MAP for even 5 minutes could cause irreversible ischemia in the brain.
The brain is just totally unforgiving. The kidney can take a hypotensive hit for 10 or 15 minutes and often recover. The brain cannot.
Exactly. So in TBI, that gap of uncertainty with the cuff is just unacceptable. You need that beat-to-beat data to protect the brain.
What about the open label bias? Everyone, the doctors, the nurses, knew who had a line and who didn't. Did that change how they treated the patients?
This is probably the most fascinating psychological component of the whole trial. Think about it. In the invasive group, the clinician sees every tiny dip in blood pressure. Oh, the MAP just dropped to 60. Let's give 500 cc's of fluid. Oh, it dropped again. Let's go up on the levo by 0.01. Oh, the pulse pressure variation is a little high. Let's give some albumin.
They're constantly tinkering. They're micromanaging the numbers.
They are. And the original hypothesis was that this micromanagement would lead to better outcomes. But it didn't. In fact, the data shows the invasive group got slightly more fluids and more vasopressors overall, but they didn't have better survival or fewer days on organ support.
Which strongly suggests that all that fine-tuning we do, all that optimizing the waveform, it might just be noise. We are treating numbers on a screen, not the patient's actual physiology.
It challenges the very foundation of goal-directed therapy. If seeing the data leads to more interventions that don't actually help, then the data itself might be the problem. It's a concept some people call information toxicity.
Information toxicity. I love that. The idea that too much data can actually poison your decision-making.
Dr. Gershengorn really hones in on this in her editorial. She asks the question, does the A-line improve the patient's physiology, or does it just improve the provider's confidence? The answer from this trial seems to be the latter.
Let's pivot to that editorial and the broader philosophy. We're moving beyond the data and into the culture of intensive care. Let's talk about de-adoption.
De-adoption is, without a doubt, the hardest thing to do in medicine. It is so easy to add a new drug to our formulary. It's easy to learn a new procedure. It is incredibly, profoundly hard to stop doing something that you have done and seen done for 20 years.
Because it feels like taking something away from the patient. It feels like you're providing substandard care.
Exactly. There's this concept called regret aversion. If a patient dies and you didn't put in an A-line, you will torture yourself. If only I had known their pressure was dropping, maybe I could have saved them. But if a patient dies with an A-line in, you can tell yourself, well, we saw everything. We did everything we could. That fear of regret drives so much of our overtreatment.
And Gershengorn calls for a fundamental shift in that culture. She says we need to start valuing less invasive as a quality metric in and of itself. How few tubes did you use to save this life? Should be the badge of honor, not how many machines did you manage to hook them up to.
I couldn't agree more. She also addresses the training aspect, which is a big concern. I can hear the residents and fellows screaming right now. If we stop placing A-lines routinely, how will we ever learn to do it?
It's a valid fear. Procedural competency requires volume.
It does. But Gershengorn makes two excellent points.
Right.
First, there will always be sick patients who truly need a line. The BMI 50s, the TBIs, the ones on massive pressor doses. So the procedure won't vanish. The indications will just become more appropriate. Second, we have high-fidelity simulation. We shouldn't be using human beings as practice pincushions just to hit a residency quota.
That is a hard but necessary truth.
Yeah.
I need to lug my numbers for graduation is not a valid medical indication for an invasive procedure on Mrs. Jones.
Precisely.
So let's bring this all home. Let's talk practical application. It is Monday morning. You are on rounds in the ICU. You have a patient with pneumonia, septic shock, on 0.2 mixed-glomin of levobase. Their BMI is 32. What do you do differently today because you read EVERDAC last night?
The new rule in my head is cuff first. It's the default. So I do not order an A-line reflexively for that patient. I look at the patient. I see the cuff is cycling well. The numbers seem reasonable. I order the cuff to cycle every 5 to 10 minutes. And I have a conversation with the bedside nurse.
What does that conversation sound like? How do you handle the pincushion pushback? The nurse says, Doc, this is going to be a nightmare. I don't want to have to stick them for labs all the time.
You have to be honest and collaborative. You say, I know this is harder for us, but the data shows it is safer for the patient's artery. It reduces their risk of a major bleed by over 80%. So let's try to work together on this. We'll try to batch labs. We won't check ABGs every 4 hours just because we can. We'll trust the SpO2 unless something changes.
And that's a key point. Reducing the frequency of lab draws is part of the de-adoption process. If you don't have the easy access to the line, maybe you realize you didn't actually need that Q4-OT blood gas anyway.
Exactly. The inconvenience of the stick acts as a natural and probably healthy gatekeepers against unnecessary testing.
And what are your personal rescue triggers? When do you finally cave and say, okay, let's put the line in?
For me, it's a few things. One, obesity. If I look at the arm and it's a cone and the cuff is struggling, I just put the line in. Don't fight physics. Two, arrhythmia. If they are in atrial fibrillation with a heart rate of 140, the cuff is going to be garbage. Line in. Three, the escalation trajectory. If the pressor dose is doubling every hour, I don't wait for that 1.25 number from the trial. If they hit 0.4 or 0.5 and are still climbing fast, I want the line because I suspect they are crashing and I'm going to need that beat-to-beat data.
That seems like a very sensible middle ground. You aren't being a cowboy and waiting for the patient to be peri-arrest, but you're also not placing it just because the levo-fed pump is turned on.
Right. It's about being thoughtful rather than reflexive. It's about asking, does this specific patient need this invasive device right now? Instead of, does shock need an A-line?
And for the listeners who want to implement this in their own units, don't do it alone. You need to talk to your nursing leadership. You need to talk to your respiratory therapists. If you just start refusing to place lines without explaining the why, the bleeding risk, the mobility benefits, the data from this trial, you will just be seen as the lazy doctor.
Communication is the most important intervention here. Explain the data. Frame it as, we are doing this to avoid harm. Most bedside clinicians will absolutely get that. They don't want their patients to bleed either.
One final thought from me on the hidden harms. We talked about sleep deprivation. We talked about pain. But think about the family for a minute. When a family walks into an ICU room and sees their loved one tied down with tubes, lines, and sometimes restraints to protect those lines, it looks terrifying. It looks like the patient is a hostage to the technology.
It does, and removing the A-line removes one of those critical tethers. It allows the patient to bend their wrist. It allows them to hold their grandchild's hand without triggering a high-pressure alarm on the monitor. That matters. That is the humanization of the ICU that Dr. Dershengorn wrote about.
So in the end, EVERDAC isn't just a study about catheters. It's a study about freedom. Freedom from tethers, freedom from complications, and maybe freedom from our own anxiety as doctors.
I love that framing. That's exactly right.
We have covered a lot of ground here. We've done the math on tartrate versus base. We've dissected confidence intervals. We've looked at the bruised wrists and the sleepless nights. If you had to boil it all down, what is the final provocative thought you want to leave our listeners with?
The takeaway is, trust the cuff. It is better than you think. The patient is tougher than you think. And that security blanket of the A-line might be comforting for you, the provider, but it's often itchy and surprisingly dangerous for the patient lying in the bed. De-adoption is hard. Are we brave enough to do less to achieve the same or even better outcome?
Be brave enough to do less. A perfect place to end. Listeners, please check the show notes. We will link the NEJM paper, the Dershengorn editorial, and, most importantly, a tartrate to base converter so you don't accidentally overdose or mismanage your patients based on a European paper.
Please do the math.
Always do the math. Thanks for diving deep with us on this first edition of Prism Rounds. We will see you at the next bedside.
Stay curious.